Maybe it will help.
And I don't know if you had a chance.
Barbara?
To look at the chat.
Hi.
Hi, Barbara.
Hi.
I don't know if you had a chance to look at that document. I added a couple that came in today while I was out of town. Some of them are kind of long, and we want to try to maybe edit them down and make them manageable and group them. So.
Hi, everybody. I am here. Had my second vaccine today and feeling pretty lousy, but I am here and I'm going to have my camera off. But
Thank you for
I'm
coming.
here in support.
Thank you.
No, I didn't see that document, but that's okay.
Hi, Pam.
Oh, Lynn and Dave, for the questions that did get submitted, you can hear me?
Yeah.
Okay. I did have something to say about the one from Jane Nelson about marginalized folks.
Mm-hmm.
So at some point, be great if you ask that one. And then also the one from Sandy about chemical sensitivity.
Mm-hmm.
I have some thoughts about that one.
Okay.
And then the other ones, I could say something, but that's okay.
Okay. We've got some good ones. You know, one of the things that's really been fascinating is we posted this on our Facebook page, and I think we did a little advertising thing. You know, you spend $10 and it goes to a slightly wider group. And I'm not sure how we did that, but I think also because of the Eventbrite is findable, right, to the public at large. And so we got a larger community. And one of the things that was fascinating is we got a lot of folks who were like, never going to do it, not going to vaccinate. And by a lot, I mean 4, you know, so bigger than folks in my world in terms of the number of people who have not only vaccine hesitancy, but sort of beyond vaccine hesitancy. And one of them posted a link to a doctor. He had capital DR period in front of his name. And so one of the things that I think will be really interesting to talk about tonight is this larger question of like, how do you assess? Oh, that's my phone, excuse me. How do you assess where you get your information from, right? I mean, this is the problem with, you know, the ability to find information that supports your position on the internet from myriad sources. So like assessing that kind of stuff. So that'll be interesting. It's 7 o'clock. My name is Dave Peedy. I am the board chair of an all-volunteer nonprofit called Berkeley Disaster Preparedness Neighborhood Network. Love that acronym, BDPNN. We're going to come up with a better one someday, but that's what we're working with right now. This is a great organization, wonderful working board, and I'm really pleased to be a part of it. And we get to host things like this, where we can bring the community together to listen to people who have a lot of skill sets and knowledge about certain things. And Barbara Morita, who's going to be in conversation tonight, has worked with BDPNN before in terms of giving us advice, giving guidance as a community, and even doing great things like disaster first aid response, real practical stuff, but also talking about the importance of community in disaster response. And this pandemic is very much like that. So we're going to give it a few minutes in case people are caught in traffic. The Zoom traffic out there, I've got 7:01. We'll give it a few more minutes. But you probably, if you signed up through Eventbrite. And we had, you know, certainly information about the folks who are going to be in conversation tonight. Dr. James Marks and Barbara Morita. And then the fact that we're going to have a Q&A afterwards. We ask for people to submit their questions via email if possible beforehand, and we've kind of done that. We will also try to address any questions that come through the chat. We're probably going to try not to interrupt the conversation that they have with questions unless we feel like there's some misunderstanding that's happening out there that is important to bring up right away. So we're going to hold off on the question part until the second half. Roughly, I'm thinking hour tops. I get really burned out on Zoom after about 60 minutes and I start fading. And so I'm sure a lot of you feel similarly. Maybe after the conversation component of this, we can all just take a little like stand-up break and stretch, even though it's only half an hour into it. I think that's always good to have that kind of break. And then we can kind of go through and address some of the questions that have been submitted. So tonight's session is called Vax Facts. That wonderful little title was created by my lovely wife, Tanya, who loves wordplay. So I do want to talk about a couple of things before we dive into tonight's discussion. And that is that BDPNN, this all-volunteer nonprofit, is doing a number of really interesting things that you may want to be a part of. Please feel free to go to our website, which Lynn Zumo, who is the VP and is going to wave right now, is going to put in our URL into the chat. Go there and you can sign up to be on our mailing list or in the discussion group. Both of those are fine, and we'll let you know about some of the things that are going on. So one of the interesting things is that BDPNN is the umbrella organization for an amazing grassroots effort that has sprung up here in Berkeley. It started a little over a year ago, called Berkeley Mutual Aid. This is mutual aid at its best, where it's people coming together to support each other in difficult times. And they've really stepped up to do that. We've got over 500 people who've been supported by other people, but it's mutual people supporting each other. If you're interested in getting involved, you can go to berkeleymutualaid.org.
I'll also put that in the chat.
Thank you, Len. The other thing I want to talk briefly about is that we started before this pandemic came upon us an amazing program because we were gifted some amazing, some money from some amazing organizations to basically provide education and go kits to seniors and people with disabilities. That was put on hold during the pandemic for a ton of some obvious, some not so obvious reasons. But that is gearing up again. If you are interested in being a part of that, that means volunteering to help out with that, or if you're interested because you fall into one of those community spheres, you can sign up at the website, the BDPNN network.org website. So please feel free to do that. The other thing that I wanted to talk about is that we are working with an amazing group called Be Certain. BECERTAINN. I don't know if you want to put their...
I'm going to do that too.
So this is a GMRS, a repeater radio organization. Sounds super technical, but they're all about connecting the community to get together and preparing in case we have communications issues with a disaster. And they are doing this amazing exercise on April 17th. That is listed on the calendar of our BDPNN org, and I recommend that you do that. We're going to have a broader community planning meeting on the, I'm going to say the 8th, because I think that's right, but it's on our calendar as well, where we can talk about how, if you're interested in radios, you can be a part of that event. If you have no interest in radios, but still want to be part of participating in a quake scenario disaster response drill / exercise, you can be a part of that, and you can be part of the community and figuring out what the best way is to do that. So that's all the housekeeping I have left to do. I think what I'd like to do is, because everybody got an email and on the Evite, they were given the bios of our two conversationalists tonight. I'm gonna let you introduce yourselves again, starting with Barbara, and maybe just focus on the parts that you feel are really relevant tonight. So I would like to introduce Dr. James Marks and Barbara Morita, and I'm gonna step out of here and let them take it away.
Okay, so I'll start off. I'm Barbara Morita. I'm a physician assistant, and for over 30 years, I worked at the various nonprofits in the Bay Area, kind of in the Oakland, Berkeley area, including Asian Health Services, La Clínica de la Raza, Healthcare for the Homeless, Berkeley High School Health Center, and I do disaster medical. So I've been doing a lot of trainings in the neighborhoods around disaster first aid and disaster triage, which has been a blast. And thank you for having me do this. Dr. Marks?
Thank you, Barbara. So I'm Jim Marks. I'm a UCSF professor of anesthesia. But in my day job, I worked at Zuckerberg San Francisco General Hospital as an anesthesiologist and also as part of the executive team as chief of performance excellence. However, for the last, actually, this is my responsiversary. So for the last year, I have been redeployed as what's called the disaster service worker to San Francisco, the city and county of San Francisco's COVID command center, where I served as advanced planning unit lead, one of the incident commanders, and for the last 9 months as the planning section chief. And that's our cat Scooby, who loves to participate in Zoom.
Dr. Marks, we're getting a note in the chat that it's a little hard to hear you. I'm not sure if there's a, if you can move up just a little bit. Thanks. Let's try that.
Okay, let me see if I can. Let me see if I can switch my audio to my screen.
Okay, that's even better.
Is that better?
Right there. Yeah, it's better right
That's
now.
done better.
All right.
Great, thank you.
Well, this is an excellent segue because what I was going to suggest is that before we jump into the main part about COVID, Dr. Marks, if you could talk a little bit about what is a COVID command center for the city and county of San Francisco? Why does it exist? What does it do?
Great question, Barbara. So the COVID Command Center is the city and county of San Francisco's unified response to the COVID pandemic with the goal of reducing transmission, limiting hospitalizations, reducing deaths from COVID. It was established in January of 2020 under the unified command of the Department of Public Health, the Department of Emergency Management, the Human Services Agency, and the Department of Homelessness and Supportive Housing. It has had between 800 and 1,000 FTEs, a budget, an annual budget of in excess of $800 million, about a little over half of which is covered by FEMA. And it's been run out of the Moscone Convention Center since there have been no conventions. And the CCC basically has coordinated and in some cases run COVID testing, case investigation, contact tracing, hospital bed utilization and management, housing of vulnerable populations, and most recently, vaccination.
Yeah, it's thanks for the explanation. It's fascinating to understand all of the pieces that go into some of the decisions that are made. Sometimes it's just, you know, the mayor or some particular person who's the spokesperson, but these are the folks who are the underpinnings for the data and analysis that goes into the decisions that are made. Is that right, Dr. Marks?
Yes. So, I mean, it's interesting. So in a typical incident response, there's an incident like a hurricane or an earthquake, and it is short-lived. There's a response to that incident and then a recovery. And in typical incident command, advanced planning is considered to be like 3 days out would be very advanced. So in our advanced planning unit, we look literally months out. And so very early on, we built the data capture and analysis tools that provide our situational awareness And we were very early on to embrace modeling of case numbers and hospitalizations so that we could literally predict out into the future, for example, whether we would or would not run out of ICU and hospital beds.
Mm. Okay, so for those of you who are listening, I want to give you a quick roadmap. We're going to start out in talking about an overview of kind of where we are in the pandemic. And from there to look at kind of where we are in the recovery, and that will be Dr. Marks speaking about that. And then we were going to focus on vaccinations and vaccines, which is something that I think that everybody is right now very focused on. And so those are the three main things that we have planned to talk about. And then we'll be taking your questions, which there have been some outstanding questions that have already been asked. But that's where we're going. So question for you, Dr. Marks. How do you feel like we're doing here in Berkeley, the Bay Area, San Francisco, and California, both in how we're doing and where we've been, and also related to how the rest of the nation and the rest of the world is going? So how would you describe the journey that we've been on so far?
Yeah, so great question. Thanks for the opportunity to ask that. So as a nation, we have one of the worst COVID outcomes of any country in the world. We have the most cases, and we have the most deaths, now at about 540,000. And we have one of the highest population-based death rates at 177 deaths per 100,000 population of any country in the world. And I think it's important to realize that at least 2/3 of these deaths were probably preventable. For example, if the nation had San Francisco's COVID death rate, there would be about 350,000 fewer deaths.
Wow.
So that's just perspective. California has done better than the nation. Our aggregate death rate in California is about 150 deaths per 100,000. And Northern California, and I would say especially the Bay Area, has done much better than California in general. As I said, San Francisco, so Berkeley has a population-based death rate of 31 per 100,000, San Francisco 54, Contra Costa 67, Alameda 87, and Santa Clara 101. So the average there is, about less than half of the California average. So overall, the Bay Area has done better than the state and much better than the country. So with that perspective, California and the Bay Area are currently coming off of our third surge. The third surge was our largest surge, both in terms of cases and hospitalizations. The cases and hospitalizations peaked in January, were well down, coming down the backside. And much of the Bay Area is progressively reopening their economy under the state's blueprint for safer economy. So many of the Bay Area counties have moved from the most restrictive purple tier to the red tier to the orange tier, with a few more current still being in the red tier, like Contra Costa. The Alameda, Santa Clara, San Mateo, Marin, and San Francisco are all in the orange tier. With case rates, and let's say our case rate in San Francisco is 4 cases per 100,000, and we peaked at over 50, so over 10 times higher than that. And with cases in the East Bay a little bit higher than that. So generally speaking, in the Bay Area, California, cases have fallen and hospitalizations have fallen dramatically after the third surge. And the same is true largely in the country, but what we're seeing certainly nationwide, and especially in some states, is that decrease in cases has stopped, And in some states like New Jersey and Michigan, cases are starting to rise again. In San Francisco, we've probably hit our nadir and our cases are slowly drifting up. So in many ways, we're in a race right now between getting a critical percentage of the population vaccinated and having a fourth surge from too rapid reopening of the economy and an increase in contact rate.
So you mentioned about the risk of, opening up too quickly. How do you think we're doing in California?
So I'm most familiar with San Francisco, but I would say in the Bay Area in general, we're doing pretty well. Businesses are relatively open. Indoor dining has started back up. Outdoor dining, and while we've seen cases have stopped decreasing, they're at a very low level right now. And while they've started to increase, I would say the rate of increase right now is manageable. But I would say also the next 4 to 6 weeks are going to be really critical as we push vaccination rates towards herd immunity. If we let our guard down, if we stop wearing masks and stop social distancing, we could easily have a fourth surge of cases and hospitalizations.
So it sounds as though if we're looking up at the horizon, that we're hopeful that we may be moving towards a recovery. But so are there other major forks in the road that you see? You mentioned about masking and not opening too fast, but in our road towards recovery, are there other signposts or things that we need to look for? And why are you thinking 4 to 6 weeks from now as being very important?
So in San Francisco right now, we have 45% of the population, 45% of the eligible population, which means the population above 60 years old, has received the first dose of vaccine. And our projections are that by the middle of May, given a willingness to be vaccinated, 80% of the eligible population will be vaccinated. And by the middle of June, 80% will have completed vaccination. And that is a level that will probably be close to herd immunity. It's probably not above herd immunity because it's 80% of the eligible population, not 80% of the entire population. But that's why the next 4 to 6 weeks. And literally every percent of the population that's completely vaccinated is a percent that won't get severely ill, won't go to the hospital, and will not die. And probably has a significantly lower risk of transmitting disease. I think that's a little less clear how effective the vaccines are at preventing infection and actually reducing transmission. But there's no doubt they reduce severe disease, hospitalization, and death. So that's why the 4 to 6 weeks. I mean, it's literally a race between reopening, increased contact, a rise in cases and hospitalizations, and preventing that from happening through vaccination and immunity. And then after that, so to say, the potential. So the potential risks are our vaccination rate does not continue to rise, either because supply gets limited, although it looks more like supply is going to increase, because a significant fraction of the population decides they don't want to be vaccinated. We open too quickly. We stop the behaviors that have prevented transmission, like masking and social distancing. or one of these more transmissible or more lethal variants takes over in the Bay Area. That would be another, let's say, potential hiccup. But despite all of that, we're pretty optimistic. I mean, the signals that we are seeing, even in the face of reopening, will lead us to be optimistic. We think probably we are going to be okay. We will be able to open as we are opening. We will continue to vaccinate the population, and we may see a surge, a smallish surge in cases. We may not see a surge in hospitalization because a large fraction of the people who go to the hospital, the elderly, have already been vaccinated. So yeah, cautiously optimistic.
Yeah, I think also that the fact that we were able to focus on healthcare workers and the elderly and those in communal living is tremendous in terms of decreasing the number of deaths and hospitalizations. You know, that the number of cases will still continue to, it's going to still move through the population, but the deaths will hopefully drop off.
Yeah, that's a great point. We haven't seen a death in a skilled nursing facility in San Francisco since January.
Wow. Yeah.
I mean, and the other thing we have not seen is we have a very sophisticated hospital database where we get direct electronic feeds from the electronic health records of every acute care hospital, and we can match that to the vaccination database. So we've seen no one hospitalized more than 14 days after the first dose of vaccine.
Wow. That's very, very hopeful. That's early, like not even in the study level, but that's great news to have, because it looks as though it's working. So let's move directly on to vaccines and vaccinations, which I think is something that's on everybody's mind right now. So could you walk us through, I think there's at least 4, but the Pfizer, Moderna, the Johnson & Johnson, which is also sometimes called Janssen, and I don't know if you want to include the AstraZeneca, but what are the differences between those different vaccines, and do those differences make a difference? And I think the question everybody's asking is, should I be worried about which one I get or which one I got? Big question.
Great questions. I'll give you the bottom line. I'll give you the bottom line answer to your question right now, and that is, we should take the first vaccine that we're able to get if we haven't been vaccinated. So first of all, it's remarkable that there is a vaccine.
And do you see differences, like the Moderna and Pfizer are messenger RNA and the Johnson & Johnson is something else? Does that matter?
So there are 3 vaccines that are approved under emergency use authorization by the FDA, which means they've all undergone extensive clinical trials involving tens of thousands of volunteers. But they have not met the typical review process for FDA approval. So they're approved under emergency use authorization. There are 2, as you said, messenger RNA vaccines. They're the Moderna and the Pfizer vaccines. And so they basically have a synthetic gene made out of ribonucleic acid RNA that encodes the spike protein of SARS-CoV-2. And that gene is put inside of a lipid or fat particles, and those are injected, and they're taken up by our cells, and that messenger RNA is then turned into DNA and back into messenger RNA, and then into protein, the spike protein, which is what we actually mount the immune response to. So the nice thing about both of those, so first of all, there's been no vaccine approved using that technology previously. So this is it's novel, but it's also one of the reasons that we have a vaccine so quickly, because it's technology that can move forward quickly. And it's also what's called platform technology. So for example, if one of these variants that has a mutant spike protein sequence gets going, it's pretty easy to re-engineer the vaccine, insert a different gene that encodes the new spike protein, and have that approved because you have a vaccine that is almost identical to the one that's already been approved. In fact, that's what happens with the influenza vaccine every year, right? The sequence of the vaccine is changed to match the sequence of the current influenza virus. So both of those vaccines require 2 doses, either 21 or 28 days apart, and they require a cold chain. In other words, they need to be kept very cold. So both of those features make them, I'll just say, a little more challenging to administer, and make them much more, I would just say, useful in like mass vaccination scenarios, because once you thaw one of those vials, you have to use all of the doses or waste them. And both of those vaccines were studied largely in the United States, and they're basically 100% effective at preventing death and preventing hospitalization, and around 85 to 95% effective at preventing severe disease. And they were approved very close to each other. The Johnson & Johnson vaccine it also uses, I'll just say, DNA technology, but in this case, the spike protein gene is inserted into an adenovirus, and it's an adenovirus that cannot reproduce. It enters your cell, the spike protein DNA is translated into protein, and you mount an immune response to that. And this vector actually has been used for viral vaccines against other pathogens.
And the adenovirus is basically a cold virus.
Yep. That's right.
Yeah. Oh, I'm seeing little chats that you're a little bit difficult to hear, so scooch up close to your microphone.
All right, is that better?
Yep.
Okay.
Good.
I'll keep leaning forward. So the J&J vaccine is also 100% effective at preventing deaths and preventing hospitalizations. In the clinical trial data, the actual percent reduction or prevention of severe disease is lower if you compare it to the Moderna or the Pfizer. However, it's important to keep in mind that it was studied in a very different clinical trial population, because it wasn't studied exclusively in the United States. There was a large fraction of the study patients were in the United Kingdom, where there's the B.1.1.7
Right.
Variant that is more contagious and more lethal, and in South Africa, where they have a variant that is also partially vaccine resistant. So from our perspective, those vaccines in terms of preventing severe disease and deaths are comparable. There's no difference between them. And we use all 3 of them, although we have to date received very little Johnson & Johnson vaccine.
Yeah, I've been giving vaccinations over at Fremont at a few places, and I've started to see the Johnson & Johnson. So it's there, it's coming. We were using it at one of the pop-ups. I have kind of an analogy, that comes to mind about choosing, worrying about the vaccines, which is if you were on a ship out to sea, and on that ship, you noticed that there were 3 different types of life vests from 3 different companies. And you did your research and you found out that, well, one actually, is a little spiffier than the other, but all of them met the safety requirements to keep you from drowning. And your ship hits an iceberg. And as you're evacuating onto the lifeboats, the crew is handing out life vests. at that moment, that might not be the moment to quibble over whether this life preserver, which actually will save your life and save you from drowning, came from, which brand, because all of the life vests on that boat will keep you from drowning.
Yeah.
So to me, that's kind of what it feels like with COVID, that all of the vaccines will keep you from being hospitalized and dying, even though there are other differences among, other characteristics. And
Yeah.
to be able to get that life preserver is good.
Yeah, I mean, and this level of efficacy, 100% for hospitalization and death is really high. I mean, influenza, I mean, there are years where, 50%, right? So, the fact that these vaccines are so effective and safe, and we have 3 of them in our armamentarium is pretty remarkable.
Yeah.
In a little over a year.
Mhm.
And then the AstraZeneca vaccine is also uses DNA technology. The gene is inserted in a chimpanzee cold virus, and that's what's injected. And then again, your body makes the spike protein, and you mount an immune response to that. The data from AstraZeneca has not been presented to the FDA, so it's not generally publicly available. What AZ has said is that it is 100% effective at preventing death and hospitalizations. There have been some, I would say, very rare instances of blood clotting, primarily in women over the age of 55 years old, potentially who had underlying very rare blood dyscrasias. But I really don't know enough about that, or whether there will be any restrictions in the United States on who receives it. I would anticipate that it will get approved in the United States, but I think it's unclear how deployed it will be in the United States, especially given that we purchased more than enough Moderna, Pfizer, and Johnson & Johnson to vaccinate the entire population.
Yeah, because the AstraZeneca has been used widely in the UK and is spreading around in Europe, right?
Yes, and in South Africa.
And I think that this is, to me, that looking globally, this actually makes a lot of sense. That we've got different, what we can get available in different countries may be different, but if they are all effective in preventing hospitalizations and death, that we're still going to be able to get the outcomes that we're really hoping for. So I think we can move on to the questions at this point. I'm going to hand this over. So Dr. Marks, thank you so much for your insight. And I think these questions are going to be also very, very interesting. So I was going to hand it over to Lynn and David.
Thank you so much. First of all, let's just it's 7:35. We've been on Zoom. Feel free to take a moment just to stretch, breathe. Everybody take self-care, do what you need to travel through. So this is not necessarily a long Zoom night, but this is a lot, right? A lot of information. I think people are stressed out, obviously, by a pandemic, but also in terms of trying to figure out how we navigate our way through. And I love that the conversation, and I think the Q&A portion too, is really going to help relieve a lot of that stress, I hope. And I love that you guys have already talked a little bit about the Bay Area and the context of California and the context of the United States and beyond. Because I think, one of the good things is that, and we can talk about why later on if we want to, but the Bay Area really has done a phenomenal job in terms of getting everybody on board in terms of how to respond around, masks and sanitizer and same now with vaccinations, right? I mean, it's really about education. It's about how do you address misinformation and disinformation. And, this is a problem that obviously our country, our planet is struggling with above and beyond just vaccinations. We have lots of political dis and misinformation happening out there, and sometimes there are campaigns around it, sometimes it's just happening. But now we're talking about something that's really just life and death for a lot of us. And so the fact that things are going well here is wonderful, but at the same time, we all have friends and loved ones who live elsewhere who are struggling with larger percentages of populations that if they're not vaccine hesitant are vaccine, like not gonna do it, like just beyond resistant. And so that's gonna be, I think on some level, frame some of the questions that I'm gonna be passing along to you. We've got a lot of questions. I'm gonna be upfront. We're not gonna be able to get to all of them tonight. It's just not possible. But what we are gonna try to do is maybe get some answers to some of the questions that we don't get to tonight, and we'll send them out. If you are on here through the Eventbrite program, we can send out follow-up emails to you. Thank you for attending, but also providing you with some links to documents that will hopefully answer some of those questions. So thank you all for coming tonight. And if we don't get to everything, that's okay. Hopefully more will happen later. The other thing is, if you know people who couldn't make it tonight, we are recording this. We are going to post the link on the website and in the Eventbrite follow-up email so that you can share this as well. Okay, so Lynn's been doing a great job going through and vetting some of the questions. By vetting, what we mean, so we're kind of trying to group them a little bit, edit them down. Some of them were quite lengthy, and for good reason. There's some great sort of stories and background that have been provided with these questions, but we obviously are pressed for time, so we're not going to get too far into it. But one of those top questions is going to be, how do we talk to friends, relatives, sometimes people who we're not necessarily that close to, who have expressed vaccine hesitancy? How do we convince them? And obviously, you know, you've talked about, you know, some of the facts and figures behind it, but sometimes it's not always just a question of facts and figures.
Yeah, great question. I mean, I think it starts with listening, trying to, you know, understand what's the why behind the vaccine hesitancy. I'm not. I think it's a lot more than, you know, just regurgitating that, you know, the data that the vaccines are safe, that they're effective. I think it's really trying to get down to understand, you know, the whys behind the reticence.
I think that's a good point. And some of the questions have sort of broken down some of that stuff. So for instance, one of the questions is, there's concern around long-term side effects around the vaccine, not necessarily efficacy issues or whatever, but are there things, you know, for instance, what happened with the AstraZeneca and people got freaked out about potential blood clots and that kind of thing. Are there any other things that they should be paying attention to if they have underlying health considerations, that kind of thing?
So in one of the previous surges of unaccompanied minors coming across the border, I spent a week in Texas. And I was stunned. It was as if we had come from different planets. So I kind of feel, you know, having had that experience with people who I respected and was doing, you know, disaster medical work with, I think that trying to convince them is not necessarily possible, in that they have been hearing a whole different set of facts and information than what I have. I mean, their sense of reality was really, really very different. But I think that what we can do and do, and I think we sometimes do this in families when people don't all, you know, kind of come from these very different points of view, is that I can't control what you do, but I can control what I do. So that if we are in a family situation, or you're going to be going to visit the grandchildren, you know, someplace, that it is appropriate to negotiate boundaries. In other words, you may believe this and I believe that, but if we are going to get together and have a family reunion, then where is the middle ground? But feeling like I'm right and they just don't understand I think is pretty hard, but setting boundaries and negotiating, okay, well, I'll come over if, I'll bring the kids if we can do this. And then just kind of work from there. The other thing that has always occurred to me is that this could be downright Darwinian. I was reading in the Chronicle about the percentage of Democrats that are planning to or willing to vaccinate was like around 92%. And the percentage of Republicans was around 50%. And I was thinking, this could actually change demographics in the United States. And I think that nature also will convince people, because I think like a lot of other things, as people know more people who get sick, that is also convincing more than me trying to argue with them by sending them another article from the Chronicle.
Thank you. Can we talk a little bit about availability, and specifically around more marginalized? Somebody wrote in about more marginalized communities, specifically, folks who don't necessarily have access to a computer, to a smartphone, to the internet. They have, English may not be their first language. What can be done about that? And actually, I'm interested, if possible, to bring in another voice, and I'll try to see if I can to unmute her, and that's Gradiva, a cousin from Berkeley Mutual Aid, because Berkeley Mutual Aid has been working to support people in terms of getting signed up and getting transportation to vaccines, because I think she has some firsthand experience, one in dealing with people who are really struggling with the vaccine question, but also we really want to point out that if you know of people who are needing support and needing help, Berkeley Mutual Aid is a great place to go to. So they have a phone number. We'll put it in the chat eventually and in the outgoing email, so that if you know people who need support in doing this, please feel free to reach out to them. So I'm going to see if I can find Gradiva on the list.
While you're working on that, so my background is that I have been doing disaster medical response. So I was at the Superdome in Katrina and saw the inequities there. Also, kind of people in Haiti, where the women and children were getting shortchanged when the more able-bodied men were able to get to the food faster and things like that. And I think that in disasters, that that the federal government can do certain things, and that's kind of what the mass vaccination sites were, which get up the numbers. But reaching those most vulnerable and most marginalized populations really has to do with the engagements of the locals. And I was really pleased to see in the Bay Area, where a number of the counties fought to keep control over that final mile of where the vaccines are going to go. And I think that that's the right direction, because the feds aren't going to know how to get to the most marginalized populations. So some of the things that I've seen, so I've been vaccinating over at Fremont High School, which is in East Oakland, and kind of seeing how that goes. But some of the things that I've seen that I think are really encouraging, and I hope Gradiva can add on to this, is that the feds have decided to send a lot of vaccine directly to the FQHC clinics. So those are the federally qualified health centers. So in Alameda County, that's like Asian Health Services, La Clínica de la Raza, Native American Health Center. And each of these sites usually have a target population that nobody else is serving, and that's why they exist. And in rural areas, they are oftentimes the ones out in the middle of the boondocks or in the farm worker areas. So I think that this is a very positive thing. I've read about, homeless strike teams, going to the camps and using the Johnson & Johnson vaccine, which is a single dose, which makes a lot of sense. going to the churches, mobile units. And I was just at a pop-up at Homies Empowerment, which is a storefront. Yay. I mean, this place was incredible. But it was a pop-up vaccinations site. And we did 150 vaccines of folks who I know would never have shown up at a mass vaccination site because it's, you know, they're undocumented. They don't speak English or Spanish because they speak Mom. And so those are things, you know, that I think these community sites, including the churches also, you know, are trusted partners where people will show up. And I'm glad to see it happening. And I hope that as the eligibility opens, that we continue to pour assets into those particular places. I think that's the key. You got to keep doing this. You have something to add, Gradiva?
You know, I want to be respectful of everyone's time. Hi, so I guess I don't know what the what question is directed
Oh,
at
okay.
me, but I'm happy to answer any questions if there are any.
You know, the question actually that it had to do with how do we reach some of the community that is harder to reach, that they have English language skills. And the reason I wanted to bring you into the conversation was because you, Berkeley Mutual Aid, for instance, has offered to help people who are having difficulty scheduling and having difficulty getting places. So, right, so this is in addition to what the government agencies are doing. This is the way that people can step up and support is by, you know, through mutual aid and that kind of thing. And you've been doing a little bit of that. So I thought if you want to share anything in terms of what you see as you are helping people out, that might help.
So I would describe the category of the people who, the challenges that are coming to us are primarily seniors, largely people with some challenges working with the technology. And so it's the other kind of angles that Barbara described. This is a different, you know, sort of subcategory that is faced with these challenges. So we see like as many kind of ways of being challenged as there are individuals, right? Like people who can't. The common one is someone who's trying to sign up on the site but can't get like the verification text, or it's trying to email them something and they can't get the email, or you know, just these like really basic not basic. There are technologies that I feel like some of the mass vaccination systems, especially the for-profit, you know, being run by Curative in Berkeley, which is like the biggest mass vaccinations in Berkeley, are not really designed for accessibility, and they maybe aren't totally thinking about, you know, their target audience, especially when they were supposed to be they're supposed to be focusing on people over 75. And I'm like, are you kidding me? You're telling people to upload photos and fill out all these things? You're specifically supposed to be trying to reach people over 75. That's not, you're not really thinking about your audience very well. So that was frustrating. But, you know, I serve, and there's several volunteers who, you know, we're basically like a call center. You know, we call and we will fill out the forms on people's behalves over the phone. So we'll just get people through whatever those challenges are. I think I saw somebody on the call whose husband I worked with right at the very beginning, who, you know, we had to go through this really difficult process to sign up for a like My Health account at Stanford Medical, you know, and we got through that, and it was like, which street did you live on in 1968 or whatever? It was so hard. So yeah, like there's just all these different barriers. And I think it actually speaks also to vaccine hesitancy, because I think the technical barriers, if you're like already a little hesitant, and then there's this like technology that's not speaking to you, it just sort of is the nail in the coffin for like getting people to access the vaccines. I had one person, this story to me, it just broke my heart, where I was trying to get her signed up, and in order, you know, the system was asking for her health insurance, a photo of the card and the number on it. She couldn't get me a photo of the card. And I was like, it's okay, it's actually fine. You don't really have to put that in. We can just go past that. And she was so uncomfortable with that. You know, this is a African American elder in our community who just was like, I don't know what they're going to do if they don't have my medical card. she essentially was like, it could really come back and haunt me in some terrible way. You know, like, am I going to get bills? Am I going to get hassles? You know, is something really bad going to happen to me if I don't put in, you know, if I don't sort of play their game? And I couldn't convince her. I couldn't reassure her enough. Because she just totally rightfully did not trust that this system was made for her. It wasn't made for her. It wasn't made thinking about her. And so it really broke my heart. But most of the time, you know, I'm just like a pleasant voice on the phone, and we do successfully get through the process.
One of the issues I know that has come up, and you know, this is a question for folks, is transport, right? So if you are someone who no longer drives, who has mobility issues, so there's the accessibility part. You've gotten signed up for a vaccine appointment, but now how do you get there? And this is an issue. And I know that Berkeley Mutual Aid has been working a little bit with Easy Does It a little bit. Do you want to talk a little bit about that?
Easy Does It is available to give rides to seniors and people with disabilities in Berkeley. They were charging a $15 round trip fee, and Berkeley Mutual Aid is covering that fee. I don't know for how long, Dave? For the month for this month?
So the short
Um,
answer is we're going to just make it, yeah, it'll
we're
continue.
gonna make it work. Yeah. So that to just eliminate that barrier. It's still, you know, it's still a little bit of a barrier. I think even though I think Easy Does It is amazing, but I think that people aren't always like super confident that they're going to be able to you know, get that reservation, and so that's been a little bit it caused some anxiety for people. But yeah, that's I think all I have to say about the program. Although we should put the contact info into the chat. I know people, I definitely, when I was volunteering there, I saw people come in cabs. Not a lot, but there were definitely some people who came in cabs. There were people who rented gig cars to get there. This was the drive-through site at Golden Gate Fields.
And I do want to point out that berkeleymutualaid.org also has a vaccine page with information about vaccine. It has a link to a sheet that we try to keep up to date about sort of the latest information. It's hard. We know that there's sort of, people are constantly getting bombarded with vaccine information. And so I know Berkeley Mutual Aid has been trying to sort of stay on top of that and keep that going. But if you have questions or need assistance, Berkeley Mutual Aid, I think is there.
I put the link in this chat.
Thank you so much, Lynn. Okay, so let's go through some more of the questions. Let's talk a little bit about herd immunity again. You've touched on this, Dr. Marks, but you know, some people are saying it may never be achieved. Is that true? Other than insufficient vaccine acceptance, distribution, or funds, why is it possible that herd immunity may not be achieved? Or will it be? That was a question.
Yeah, so herd immunity, which is the point at which enough of the population is vaccinated that the virus can't spread, right? So, and how high that percent vaccinated has to be is a function of the transmissibility of the virus, right? So COVID is very transmissible. It's more transmissible than influenza. And what the math tells us is that for wild type COVID, a minimum of 72% of the population has to be vaccinated, such that one person would then not infect more than one person, and therefore the infection cannot grow. It will shrink and ultimately fade away.
Can you talk a little bit about variants and how that could play into that discussion?
Yeah, so the variants are bad news because, so for example, so the R naught, or the transmissibility of COVID, is probably around 3.5, which means one person infects 3.5 people. Let's just say 3 people, one person infects 3 people, and each of those 3 people infect another 3 people, and you have this exponential rise and spread. If 2 of those people are immune, however, then one person can't infect 3. They can only infect 1 because 2 are immune. The B117 variant is probably 50% more transmissible. So now the R naught is a value over 5. And you have to get to above 80% of your population vaccinated in order for one person now only being able to infect one person. The P1 South African variant is probably 80% more transmissible. So now you need to vaccinate well above 85% of your population in order to achieve this herd immunity effect.
So you talked a little bit about the how the vaccines can be tweaked, right? Like these types of vaccines can be tweaked to accommodate that. But what about the people who've been vaccinated with the existing untweaked vaccines?
So there are trials already underway looking at the impact of boosting. So, right, so it is almost inevitable that immunity will fade. We know that natural immunity fades from infection. So once you're infected, you're immune for a while, and that immunity will fade. The same will happen with vaccination. And so at some point, and we do not know at what frequency yet, we will need booster shots. So one way of just boosting or reducing the impact of the mutants is just to boost and get a more vigorous immune response. And that's basically, that's simple because those vaccines exist. More sophisticated would be to actually change for example, RNA sequence in the Pfizer or the Moderna vaccines to more closely match that of the variants and use that to boost. That would take longer because you have to remanufacture the vaccine and probably do at least some amount of safety testing in humans as well.
So a related question that came in was, what about behaviors after we've been vaccinated, right? So I think there's both a lot of information, but also sometimes it feels like a little bit contradictory information about, literally, we get questions about like, can I hug my grandkids? Some people are saying yes.
Yeah, so the CDC has very clear guidelines on their website. They're simple, and I think they're actually pretty clear. And they basically say you are not vaccinated until you are 2 weeks after your second Moderna Pfizer or 2 weeks after your J&J. And then once you are vaccinated, you can mix, for example, with one other household unit indoors unmasked, but not with 2 and not with 3 and not with 4. You need to be masked when you are in public. Travel, either internationally or domestic, is still not recommended. Right, because it's important to, what we're trying to do is not just, so if I'm vaccinated, I'm not gonna die, I'm not gonna go to the hospital, but at some frequency, I can still get COVID, and I could pass it on to others who are not vaccinated. Whereas if I'm wearing my mask, then the probability of that happening, well, first of all, the probability that I'm going to get infected is still lower, and the probability that I'm going to transmit is markedly lower. Just as an example, so we've had 900 to 1,000 employees working in the Moscow Convention Center for over a year now, with a masking compliance rate above 99%. We've had no outbreaks. Masks are highly effective at blocking transmission, and that's why until we get to herd immunity, or maybe especially if we don't get to herd immunity, we're going to need to stay masked and socially distanced. And how far out into the future I think is unclear right now, because it's unclear how high we're going to push this percent vaccination. And that percent vaccinated, that's the total population. So we're going to need to get children vaccinated as well. It's not going to be enough to just get, 80% of the, currently over 16 population vaccinated. If we don't do better than that and don't get children vaccinated, we'll have surges in cases and hospitalizations. It's inevitable.
I think that that CDC number that you can, get together with one family, but not with two. I think that that's as if there's a light switch, when you go to two. And I think that there's the other piece of this is that there is a level of risk that people, there is an individual choice about the level of risk. So that if you are vaccinated, but you're basically healthy, and if you, accidentally caught, some COVID virus from some grandchildren, that could be a tolerable situation for you in order to be able to hug your grandchildren unmasked, where somebody else might be more medically fragile who really absolutely needs to avoid any contact. And then the other thing is that with a lot of times you could just be masked. You can still have contact with your family. Now that you're vaccinated, you're a little bit more protected. It's just that you need to be masked when you're together. So I don't think it's, then you can never see these grandchildren, but you can see these other grandchildren. I think that, there's some personal choice as to how much risk works for you and for your family, and it needs to be negotiated with everybody in the family.
Thank you, Barbara. I think that's a good context to put it in. Some of the other questions that we have gotten are around people who have other medical conditions and their concerns about taking the vaccine. For instance, I take an immunosuppressant for Crohn's disease. It's pretty mild. I've been told by my doctor no, but there are other people who are, take much more sort of intense immunosuppressants. And then there are other people who are also just sort of have multiple chemical sensitivities, and they're concerned that sometimes, society at large doesn't really recognize what they struggle with every day, even before this pandemic, and maybe their concerns aren't being addressed. Are there medical situations that we should be aware of when we think about getting a vaccine?
I can jump into that a little bit. I've been talking to people coming in to get vaccinated who are immunosuppressed or on immunosuppressants, and they tell me that their specialists, their doctors have been telling them, go get the vaccine. That, it may not work as well because your immune system is suppressed, so that you might not get as good of an immune reaction, but go get it and get the protection that you can get. Now, I think the sensitivity thing is another one, but one tip is that even the people who have been ending up with anaphylaxis, it's often been very random, and not everybody who has sensitivities has had that problem. Even anaphylaxis is treatable, so that even, if you really, really want to get that vaccine, then what I suggest is that you get it done, not at the Coliseum, right? But you get it done in the parking lot of a hospital, so that if you do have a prolonged anaphylactic reaction, that you're going to be right there at a facility that, can handle it if it takes more than one EpiPen to get you back on the road.
Thank you.
You have a reaction to that, Dr. Marks?
Yeah, I prefer not to have to treat anaphylaxis. But yeah, I think for the I think, ultimately an individual should talk to their physician about whether, there's a reason why they're not a candidate for a vaccine, but I think those instances are going to be pretty few and far between, and probably relate to specific hypersensitivity reactions in the history.
Yeah, there are particular ingredients in the vaccines, but I have talked to people who have allergic things, but not an anaphylactic reaction, and I suggest that you don't do it out at the Coliseum, but you do it near a medical facility.
It's 8:06. We're kind of a little bit past the hour, and we can go on a little bit longer. And I think what's great is some of the questions, some of your responses to some of these questions have answered some other ones as well, related and even unrelated. But I know that, you know, one of the big issues around vaccines is really just what Gradiva touched on a little bit, and Gradiva may want to weigh in on this again, I don't know, but what do you say to people who are saying, you know, Mike, who's on our board, is a teacher. I think he's in the eligible capacity right now, but he's really struggling to find an appointment. And I know that one of the things that I've heard over and over from people who have succeeded in getting appointments, just like, you got to keep at it. You got to keep at it and whatever. But is there any more advice? And Gradiva, you're welcome to weigh in on this as well. To folks who are feeling like, I can't find a way to get vaccinated, to get an appointment to get vaccinated. I think I'm in the eligible group, but I'm struggling. I'll let Gradiva talk to this a little bit, because I know she's struggled a little bit.
Sure. I mean, what you said, but that's not easy for everybody. And if somebody is a little bit hesitant anyway, the idea that they're going to spend the next, 18 days hitting refresh on a browser it's a barrier. So I guess I would also say to try to ask for help, right? Like, ask for help from Berkeley Mutual Aid, or ask for help, from your kids or from a trusted friend. I think would be good advice. Ask around, like, because now there are people like me who are getting a reputation as being good at this, and I now have like friends calling me asking for help. So we call ourselves vaccination concierges now. I'm just kidding, but I think asking for help would probably be the best advice I could give.
And that vaccination page on the Berkeley Mutual Aid site is pretty up to date with information about where there might be resources for signing up too as well, right?
I mean, I try to update that, every day or two, but again, if someone's going to do it themselves, they're probably going to need to go to multiple sites, go through the whole process at Walgreens and at CVS and at Safeway and on My Turn. And like right now, today, I've got a couple people who are 62, and so they're going to be eligible tomorrow, and I haven't found anything today. So. Okay, someone just put in the chat, my best bet was Walgreens, refreshing every 15 minutes. I do try to put tips into that spreadsheet, like crowdsourced tips. Like, some people say that Walgreens is best like early in the morning. I'm never awake early enough to test that theory. But if there are any crowdsourced tips, I try to share those as well. But yeah, it is a matter of sort of repetitive diligence. But if that's just hard for somebody, they can try to engage somebody else. It's likely that there is somebody else who wants you to get vaccinated, right? Someone in your family who wants it as badly as you do, So that's my advice.
I'm seeing another part of this, which is through the Alameda County sites, so that I know that Berkeley's got its own thing going with the public health department, but I've been vaccinating at Fremont High, and if you do live in one of the targeted zip codes, that those sites are trying to get everybody who shows up requesting to get them in. And even if you cannot prove your address, if you are willing to state, I live in that zip code, they will put you in. I mean, the word is out, they do not want to turn away anybody. And if there's a way that they can get you in, if you don't have this card, this whole thing about sending in the cards and things like that at this site, we have all these folks who have no documentation, and
But the thing is, those sites aren't really being publicized. Like, people like me who are looking for that information don't really have that. Like, I didn't know about all the Ed Roberts site that they were doing here in Berkeley. I didn't know until that morning, So it's a little bit of a gray area, because I think that the organizers are sometimes keeping things a little under the radar, because they want to make sure that they're that they're getting the people that, like, they don't want to have a bunch of carpetbaggers from, Marin County come take all the appointments.
Yeah. But I mean, this is to target those zip codes. But if you, or, if you get folks who are in any of the targeted zip codes, that the county is, those sites make it as easy as possible and try to never turn anyone away, to find out a way to make it happen,
Well, thank you. We're not advocating jumping the line, obviously, but we want to try to get as many people vaccinated as quickly as possible. That's, I think, everybody's goal. And to make sure that those folks who are in those brackets, frontline workers, and people struggling with medical conditions and people who are older, obviously those are the people we're trying to support. But if anybody has questions, feel free to visit the berkeleymutualaid.org website. Okay, so it is 8:12. Thank you so much. I will be in touch with Dr. Marks. Thank you so much for coming. Barbara, you're always a treasure to us. And Gradiva, thank you so much for chiming in with your personal experience helping individuals out. We will I'll try to answer as many questions that we did not get to. Thank you, Donald, for your opinion, and we will definitely try to get as many questions answered and send it out in an email as we can. And we'll also get the link to this video up on our website as soon as we can. We're an all volunteer organization, folks. And so we're doing our best here, and we really want to thank again Dr. Marks and Barbara Morita. Thank you so much for coming.
Very welcome. This has been a real pleasure.
You're very welcome.
Bye.
Bye-bye, everyone. Good night.
Good night.
Good night.
Thanks. Thank you, Dr. Marks.
You're very welcome. Thank you.